and the organizing committee for inviting me here. And it's always a pleasure being in your beautiful country to deliver a lecture and also to meet my friends here. So I will speak briefly about inflammation in type 2 diabetes. I would need at least several hours to cover all aspects of inflammation in type 2 diabetes, but I'll try to do my best to do that within 20 minutes. So first of all, these are my disclosures. When we talk about diabetes, we know that diabetes causes a lot of different inflammatory processes in our body. Chronic hyperglycemia is related to diabetes, is associated with end organ failure, and also there is a landmark study to correlate the inflammation with diabetes was conducted in animal models 1993. So it was more than 20 years ago, and it was investigated the role of TNF-alpha in obesity, in insulin resistance, and also in diabetes. And in that study, they found that TNF-alpha, or tumor necrosis factor, has catabolic effects on fat cells. That was a very important discovery in that period of time, because the neutralization of TNF-alpha causes a significant increase in the uptake of glucose in periphery. On the other side, they concluded that TNF-alpha plays important roles in obesity and insulin resistance and diabetes. But chronic inflammation is not just about TNF-alpha. Chronic inflammation is much more than TNF-alpha and much more than just few immune cells. So you can see it here that type 2 diabetes and obesity are linked by many different pathophysiological mechanisms, and in type 2 diabetes and obesity you can find elevated markers of inflammation and markers and mediators of inflammation, and you can find it here. It's not just fibrinogen and CRP, which we know as a potent marker of inflammation, but also interleukin 6 and many other pro-inflammatory cytokines. So chronic activation of pro-inflammatory pathways in target cells of insulin action may contribute to obesity, to insulin resistance, and also to type 2 diabetes and many other chronic diseases related to obesity. On the other side, we know that there are many inflammatory, pro-inflammatory, and anti-inflammatory biomarkers, and one of the most important inflammatory biomarkers which induces inflammation is CRP and TNF-alpha, as I already mentioned. On the other side, adiponectin reduces inflammation. So this is one of the proofs that diabetes and obesity and chronic inflammations are connected throughout the adipose tissue. And the role of adipose tissue is the role of adipose tissue sometimes is underestimated problem. Adipose tissue is just some aesthetic problem, but at the end of the day, it's not just the matter of aesthetics, it's a matter of health. So you can find it here that those markers are predictive of insulin resistance and incidence of type 2 diabetes, but also cardiovascular disease and subchronic inflammation. Subacute chronic inflammation will activate at least two major inflammatory pathways. You can see it here. One is JNK and another one is transcription factor NF-kappa B. So those pro-inflammatory pathways will cause chronic inflammation, and that can be related to many different obesity and insulin resistance related chronic diseases. On the other side, it's not about just white adipose tissue, but also brown adipose tissue could play also important role. And you can see it here when we talk about brown adipose tissue. Brown adipose tissue has important role in glucose homeostasis and also associated with insulin resistance and glucose level at periphery. But on the other side, white adipose tissue produces many cytokines, and some of them are pro-inflammatory, some of them are anti-inflammatory. So, and as you can see it here, TNF-alpha, interleukin 1, 6, 10, leptin, adiponectin, and many others. It seems that adipose tissue inflammation is important throughout the metabolic related diseases in obese people or people with obesity and people with diabetes, but several other organs also have been reported to participate in that chronic inflammation, and it's a liver, neural system, and possibly skeletal muscle. On the other side, this is the link between the adipose tissue, adipocytes, and high fat diet, which will cause the hypertrophy of adipocytes, and of course, hypertrophic adipocytes will secrete many pro-inflammatory cytokines, which what I already mentioned, but also will activate different pathways which will cause production of pro-inflammatory cytokines, and will polarization and activate macrophage, and will further elevate the inflammation, and on the other side will activate J and K activity and will cause insulin resistance. So it seems that it's not just one-way direction between insulin resistance and inflammation and organ failures. On the other side, all of us, we are aware that type 2 diabetes is not just a matter about insulin resistance. It's also about beta cell failure or beta cell dysfunction. It's better to say beta cell dysfunction. When we were 20 or 30 years ago, we thought that majority of beta cells will die due to process of apoptosis. Right now we know that some of them are undergo to process of dedifferentiation and will produce other hormones rather than insulin. So the role of pancreatic beta cell failure in type 2 diabetes is already mentioned several times in pathophysiology of type 2 diabetes. But but inflammation. When we talk about inflammation, we are not talking about inflammation of adipose tissue just, but also about inflammation of pancreatic beta cells, which will aggravate the type 2 diabetes and also hyperglycemia. And when we talk about insulinitis, it's not just about cell destruction, but also beta cell failure as well, and beta cell dedifferentiation. From that perspective, macrophage, also inflammasome and other immune cell type cause isolate autoimmunity. On the other side, there are many different pro-inflammatory cytokines which are secreted by macrophage and other inflammatory cells, but also TNF-alpha and reactive oxygen species, they play important roles from that perspective. Another part which I would like to cover briefly in my presentation is the role of gut microbiota. When we talk about gut microbiota, it's very popular to speak about gut microbiota. When we talk about gut microbiota, we are talking about not just diabetes, not just obesity, but also cardiovascular disease, NAFLD or muffled, however we call it, and many other diseases, including cancer. So from that perspective, gut lack of diversity will increase susceptibility to range of diseases, especially metabolic diseases. And today we know that people are usually decrease the amount of fibers in their food, and Western diet usually cause dysbiosis. And fiber metabolism is important because fibers cannot be digested by human digestive fluid, and at the end of the day they will produce short-chain free fatty acids, what is very important because it will have immunosuppressive cytokines level to be elevated. So when we talk about short-chain fatty acids, we know that they play important role in diabetes, in obesity, but also, as I already mentioned, in many different other diseases. And it seems that they promote secretion of GLP-1 peptide. What we know how GLP-1 and other incretins are important not just in the pathophysiology of hyperglycemia, but also in pathophysiology of many other diseases, as GLP-1 receptors are sporadically presented in many different organs. On the other side, it seems that short-chain fatty acids will decrease the grade of inflammation, and especially chronic inflammation in bowel. So Western diet, antibiotic therapies, or antibiotic consumption and microbial exposure could play important role in these biosis, and these biosis could have effect on lowering secretion of GLP-1 receptor, GLP-1 peptide, and also increase low-grade inflammation. Low-grade inflammation will cause translation of bacteria to the abdominal tissue, the adipose tissue, and will cause chronic inflammation, as I already mentioned. So gut microbiota modules inflammation, but also affect gut permeability, affect glucose and lipid metabolism, affect insulin sensitivity, and also overall energy homeostasis. These are the most important pathophysiological pathways by which gut microbiota have influence on type 2 diabetes. Modulation of inflammation, gut permeability, glucose metabolism, but also free fatty acid oxidation and synthesis of and energy expenditure. I will not go into details, but some species they have beneficial effect on, in improvement of glucose homeostasis, on glucose metabolism. Some of them inhibit pro-inflammatory effects and also secretion of pro-inflammatory cytokines. On the other side, some of them will have beneficial effect on gut permeability. Some have effect on glycogen synthesis and also the amelioration of insulin resistance. So some of species can have even can worsen insulin sensitivity and also can cause diabetes. So that's the reason why it's important to have balance between so-called good and bad species in gut microbiota. On the other side, fatty acid oxidation, as I already mentioned, in adipose tissue is also important and can be affected by some microbiota. So when we talk about new treatment options, which can target inflammation and delay of type 2 diabetes onset, we know that some anti-inflammatory properties of the non-pharmacological measures are already mentioned by Professor Milenkovic in physical activity and appropriate diet with increased intake of dietary fibers, with carbohydrates, with low GI. So many different important topics in non-pharmacological treatment of type 2 diabetes can have effect also on inflammation. On the other side, there are many different treatments, anti-hyperglycemic treatment, which can affect also inflammation or level of inflammation. So, for example, insulin can decrease NF-kappa B activity in peripheral blood mononuclear cells, which can cause lower grade of inflammation. This is just one example. I will not go into detail, but also DPP-4 inhibitors and some other metformin as well, glitazones can have a beneficial effect as anti-inflammatory drugs. On the other side, we know that SGLT2 inhibitors, they have beneficial effect on lower, and we heard that in the previous session, SGLT2 inhibitors can decrease cardiovascular death mortality and overall mortality dramatically. And one of the explanation is also the reduction in oxidative stress, but also in fibrosis and sympathetic overdrive, and also the decrease in inflammation, level of inflammation, what can be the explanation of beneficial effect on cardioprotective effects and also nephroprotective effects of SGLT2 inhibitors. So according to cardiovascular risk reduction, reduction in atherosclerosis, progression of plaques, but also reduction in renal pro-inflammatory cytokines, fibrosis and apoptosis in the kidney can cause better renoprotective effect of SGLT2 inhibitors. On the other side, there is no doubt that statin can have a pleiotropic effect, including anti-inflammatory effect, but targeting inflammation with statin does not improve glycemia, so there is no enough proofs to say that statins provide anti-inflammatory approach for people with diabetes and cardiovascular disease. Also, salicylates, also it was we know that we are using that in secondary prevention in type 2 diabetes and also cardiovascular disease. But maybe one of the most prominent drugs in the term of inflammation is TNF-alpha antagonist, and several studies did not demonstrate adequate results, unfortunately, and also interleukin-1 beta antagonist also did not reduce the incidence of type 2 diabetes. So there are so many different aspects. We are talking about the importance of TNF-alpha and interleukin beta, and if we are using antagonist of TNF-alpha and interleukin beta, we don't have any effect on the reduction of type 2 diabetes incidence, neither the results of cardiometabolic beneficial profile. So it's confusing. Results of many studies are confusing if we talk about the inflammation as very important part of type 2 diabetes and also the overall complications of diabetes. And at the end, I would like to mention briefly about COVID and diabetes. Hopefully the COVID is behind us, but we have learned a lot about the COVID, and probably it won't be the last pandemic in the world, and also we will in the future we will surface with many different pandemics like this one. But we have learned a lot from COVID regarding inflammation and regarding the possible vulnerability of people with type 2 diabetes. So we learned that people with type 2 diabetes, they were a vulnerable population for severe clinical cases and also a higher mortality rate. I will not go into details, but one of the explanation was also the ACE2 receptors, and it was also debate ACE inhibitors, should they be used in COVID positive patients or not? What about anti-hyperglycemic drug? What about SGLT2 inhibitors and modern therapies? So we have learned a lot regarding that, but we have learned that the severe COVID-19 clinical cases and severe form of disease was caused by a cytokine storm, which causes the multi-organ failure. And at the end, what we can say that increased ACE2 expression, increased furin, impaired T cell function, and increased interleukin-6 level. This was common findings in people with COVID-19 and diabetes. And dear ladies and gentlemen, dear chairperson, let me conclude. As I already mentioned, I couldn't cover all aspects of inflammation in type 2 diabetes, but I tried to cover briefly at least the most important, just to tackle the most important pathways in inflammation and pathophysiological mechanisms. But we can summarize that diabetes and hyperglycemia can cause inflammatory process in different organs. And obesity-related adipose tissue leads to increased insulin resistance, but also to chronic inflammation. There is no doubt that macrobiota is important and play an important role in gluconeogenesis, but also in the term of anti-inflammatory and pro-inflammatory cytokines and inflammatory and pro-inflammatory markers in circulation. Current anti-hyperglycemic drugs show some anti-inflammatory effects, especially SGLT2 inhibitors, insulin, metformin, but also GLP-1 receptor agonists. And the researchers are trying to target inflammatory pathways in order to stop the progression of diabetes, but it seems that the chronic complications of the type 2 diabetes. It's not just a matter of chronic inflammation. It's not enough to say just it's oxidative stress pathway, and we know that there are several pathways even in chronic complications of diabetes. And for sure, people with diabetes have high risk of severe COVID-19, but also they are at high risk to have severe influenza, to see severe pneumococc disease, or also invasive pneumococc disease. So we have to think about it, because we have learned during COVID that people who had good glycemic control, they had better prognosis in terms of COVID-19 disease. But also it's the same situation with influenza, with invasive pneumococc disease, and many other infectious diseases. So we are right now in the beginning of summer, and in the beginning of winter, and many respiratory diseases which can be prevented by vaccination. So it's important to emphasize the importance of vaccinations in people with type 2 diabetes, because at the end of the day, the education is the most important thing. Maybe we cannot find the whole solution how to resolve the problem of inflammation in type 2 diabetes, but what we can do, we can educate people with diabetes, we can educate physicians who are treating people with diabetes, people with obesity, and with other chronic diseases, because like George always said, helping others is good, but teaching them to help themselves, it's even better. Thank you very much.
Thank you very much. Thank you very much.